Thank you. Good morning, Chairman, Co-Chairman, and panelists. I'm Naruepol from Maharaj Nakhon Ratchasima Hospital. It's my OMG case, but it's the routine case from my hospital. Cases are 36-year-old man. He 6 hours sustained from motorcycle accident, have a tender at right leg, and have a large open wound. The primary survey is normal in all parameters. And secondary survey is almost normal, except only the extremity that have a large open wound at the right legs, but not seen active bleeding. This is X-ray of this case. There has a comminuted fracture of the proximal tibia with interarticular fracture, but the comminuted extend to distal 1/3 of the shaft of the tibia. For my initial management, I set around for debridement with external fixator across the knee joint. This is post-op X-ray. And I go for further investigator with CT scan to access the joint. I saw the joint is minimal displace in this case, and this is a coronal cut and sagittal cut in this case. Okay, this is a diagnosis that we have and problem list that we have to deal with. This open comminuted fracture of tibia with bone loss and minimal displaced fracture of tibia plateau with severe soft tissue injury. This is my management, because after I debridement of a wound, after 10 days, we discussed with our patient that the planning of the implant, we give patient two choice is a hybrid Isolop external fixator or put the plate inside because of the wound is very good, but you might have a risk with the infection if you use internal fixation. But he chose to have a leak with some injury of the soft tissue, and he must go for up after surgery. And my approach is anterolateral with minimal invasive approach with patient position in the supine. Implant selection, I use the lateral proximal tibial LCP with indirect reduction. You have to avoid of the injury to soft tissue that almost have a severe injury before, with bridging of the comminuted fragment. But I not use the early bone graft or any cement because of risk of infection and risk of cannot coagulate the soft tissue. Firstly, I plan to use the 3.5 screw with the wrapping, but the eye template is not have a length long enough. For in this case, I have to use the lower one in this case because I have a long enough, but it still catch over the T screw below. That I have a risk of failure of the fixation. But unfortunately, we have not fluoroscope in intraoperative case because it's my old case for just 3 years. This is post-op X-ray. So I use the small screw to keep the joint without a large opening of the joints, and then breathing of the fracture site, but it still have a minimal villus reduction. And then it's follow up after 2 months and 4 months. It's still not union, and then I put bone graft on this case. After 8 months, they have the union, but still have minimal villus of the reduction or the fixation. This is my result. After the fixation, the range of motion is quite well, and the wound is okay. Maybe the further management will go talk to the patient about high tibial osteotomy to restore the joint alignment. to scan. Okay. Thank you.